Think about how you make sense of things in your own life. A challenge, maybe, or trying to understand someone, or even just figuring out who you are becoming. What do you reach for?
Almost always, it's a story, isn't it?
Exactly. Our lives are just woven from them.
Yeah, stories aren't just little anecdotes we tell. They're more like the basic structure of how we experience things, how we interpret reality itself.
And today, we're looking at how that fundamental human thing, storytelling, is actually being used as a specific, rigorous research method. And in a field you might not expect, medicine.
Right. Highly structured, very scientific.
Our deep dive today is into narrative inquiry. We're exploring its impact, which seems pretty incredible, particularly on medical education.
And we're drawing heavily from a really compelling paper by Clandinin, Cave, and Berendonk. They lay out the theory, the practical side, and, the challenges of using stories to understand how medical learners actually develop their professional identity.
Yeah, who they become as doctors.
Precisely. And while the focus here is medical training, the ideas are much broader. This whole way of exploring experience, knowledge, identity through stories, it gives you, the listener, a powerful new lens.
For understanding your own learning.
Right.
Or professional growth, or just navigating life.
Definitely. It goes beyond just collecting facts. It's about finding deeper meaning.
Okay, so let's rewind a bit. Because medicine, maybe implicitly, has always known stories matter. I mean, think about it. A doctor asks, so what happened?
They're asking for the narrative, not just a checklist of symptoms.
Yeah, and the paper mentions figures like Richard Cole's way back, urging doctors to really listen to patients' stories. It's not just for diagnosis, but to actually deepen their own understanding of what illness is.
It was about the human element behind the biology.
That history is important, showing the story was always there, kind of under the surface, even if it wasn't called research.
Right. But the real catalyst, the game changer, seems to have been Jerome Bruner back in the 80s. He made this crucial distinction about how we know things, two different ways.
Okay, so Bruner gives us these two modes of knowing. First up is paradigmatic knowledge. This is the science stuff we recognize, right? Logic, replicable steps, empirical data, finding general rules. It dominates fields like biology, physics.
The hard sciences, very focused on measurable outcomes, objective facts.
Essential for medicine, obviously. But the authors point out, and this feels right, it's often not enough for the sheer kind of messy reality of clinical practice.
The uncertainty, the ambiguity. You can't always fit it into a neat formula. The lab bench isn't the bedside.
Exactly. So in contrast, Bruner introduced narrative knowledge.
And this, he said, deals with human or human-like intention and action and the vicissitudes and consequences that mark their course.
Okay, less catchy maybe.
Yeah. Basically, it's about things unfolding over time. It has a temporal dimension. It's not a static fact. It's a process. And this is what really cracked open the door for narrative research as a distinct, valuable way of knowing.
So Bruner's ideas kick off this, what the paper calls a narrative revolution in social sciences. Late 80s.
That's right. Suddenly, everyone's talking about narrative approaches. They just exploded.
But maybe too fast, because it led to some confusion.
Well, yeah. Exciting, but messy. Terms like story and narrative got used pretty interchangeably. There wasn't one clear definition of what narrative research even was.
Like, what kind of story are we talking about?
Exactly. Was it the small stories, just everyday conversations, the back and forth itself being the story? Or was it the big stories, like a whole life history or an autobiography? It was a bit all over the place.
Like discovering a new tool, but not quite having the instruction manual yet.
A good way to put it. And that confusion really highlighted the need for clearer methodologies. Which, conveniently, brings us to how Clandinin, Cave, and Berendonk define narrative inquiry specifically.
Okay, so let's nail down their definition, moving past that early fuzziness. They say, people shape their daily lives by stories of who they and others are, and as they interpret their past in terms of these stories. Story, in current idiom, is a portal through which a person enters the world, and by which their experience of the world is interpreted and made personally meaningful. That's quite a statement.
It is, and what it tells you immediately is that narrative inquiry isn't just about collecting stories about something. It's about understanding that experience itself is structured like a story. We live narratively.
We live in stories.
Exactly. And this builds on John Dewey's ideas about experience. He had two key criteria, remember?
Interaction and continuity.
Right. Interaction, that dynamic back and forth between us and our environment, and continuity, how our past experiences flow into and shape our present and then influence our future.
So, like, my mood right now isn't random. It's interacting with this conversation in this room, and it's connected to how I felt yesterday or what happened last week.
Precisely. It's an ongoing thread. And to help us really grab hold of this idea of experience as story, the authors give us the three-dimensional narrative inquiry space.
Okay, this sounds maybe a bit abstract, but let's unpack it.
It's actually very practical. The first dimension is temporality.
Time. Past, present, future.
Yep. Recognizing that people and events are always moving, always in process. We're not fixed points, we're unfolding narratives.
Okay, makes sense. Dimension 2.
Place. The actual specific contexts and locations where life happens, where the research happens. Think homes, hospitals, lecture halls.
So the setting isn't just a backdrop. It shapes the story.
Absolutely. An ER story feels different from a clinic story. Place matters. And the third dimension is sociality.
Sociality. Okay, what's that cover?
It's both inward and outward. Inward is our internal landscape, desires, feelings, moral reactions, gut feelings. Outward is the context, the environment, the cultural forces, the bigger conditions we live within.
So it's connecting the inner world with the outer world.
Exactly. It's the whole picture. The when, the where, the who, the how it felt, the why. It paints experience as this rich, living landscape.
Not just a flat event.
Right. And this leads to a really key distinction they highlight from David Morris, the difference between thinking about stories and thinking with stories.
Okay, thinking about stories. It sounds like analysis, right? Taking it apart, looking for themes, like dissecting it.
Pretty much. Treating the narrative like an object separate from its living context, a bit detached.
Right. So what's thinking with stories?
That's different. It's a process where the narrative, as they say, works on us. The researcher really attends to the lived experience in its full richness, the time, the place, the relationships.
So you're not just analyzing a text, you're letting the story itself shape your understanding.
Precisely. It's an engagement, it's relational, it's less about finding objective truth and more about gaining deeper contextualized insight. It's a whole different way of knowing, really, an epistemological shift.
Wow, okay. That distinction, thinking with stories, that feels really significant. It's more holistic, more empathetic.
It honors the complexity of the lived experience within its bigger picture.
Okay, so with that foundation laid, let's see this in action. How is narrative inquiry actually shaping professional identity in medicine? Because identity, as Monroe said, it really matters.
Yeah.
Who we are underlies much of what we do.
It's fundamental. Becoming a doctor isn't just about learning facts and skills, it's about embodying that identity. And this fits into a wider narrative turn in healthcare.
Which sees care less like fixing a machine and more like
being part of the art of living. It views the caregiver and the patient as co-authors in these life encounters. It's less hierarchical.
And that changes how you'd research medical education, right?
Yeah.
Before, stories might have been used, but maybe just as data points.
Often, yes. Treated as objects for analysis that thinking about stories mode. But the shift now is towards genuine narrative inquiry, tuning into the relationships, the context, the person, the researcher. It's all interconnected.
And this is where specific methods come in, like Rita Charon's parallel charting.
Exactly. That's a pedagogical tool where medical learners actually write stories about their clinical encounters, not just the medical facts, but their experience of the encounter.
And then they discuss them.
Yes, in small, facilitated groups, they do a close reading, exploring the puzzles, the ambiguities, the difficult bits of their experiences. It's designed for reflection.
That sounds intense, but potentially transformative. The paper talks about 2 specific studies using this method, right? By Clandinin and the Caves.
Yes, focused on how this process affected the learner's professional identity formation.
And they designed it carefully around those 3 dimensions.
Absolutely. Participants wrote 10 charts over 5 meetings. Crucially, always in the same hospital room highlighting place, the groups then dug into each chart together. They considered temporality, linking current moments to past experiences, maybe even childhood narratives. And they explored sociality, talking openly about their emotional reactions, their moral judgments within the safety of the group.
Let's take an example. Sarah, a resident, an experienced international medical graduate.
Right. She wrote about a difficult situation. A new mother deciding to give her baby up for adoption. And this really clashed with Sarah's own cultural background, where that felt almost like abandonment.
So how did the group help her think with that story?
Well, one person focused on Sarah's feeling of self-judgment, her moral discomfort. Another brought in temporality by asking about the baby's future possibilities. Someone else explored other support systems. It wasn't about finding a right answer.
It was about exploring the complexity.
Exactly. And through that collaborative inquiry, Sarah started to retell the story. Not as her failure to understand, but as evidence of her strength in building really deep, empathetic, patient relationships. She reframed her identity.
She saw herself differently as a doctor.
Profoundly so. She could claim that relational strength as central to her physician identity.
Amazing. And the other case, Leslie, an internal medicine resident.
Leslie struggled initially. Patients sometimes mistook her for a nurse, which bothered her. She lacked confidence introducing herself as the physician. There was this real dissonance.
A disconnect between her role and how she felt or was seen.
Yes. But over the 5 sessions, her stories changed. She brought her worries, her questions about what makes a good physician into the group. And in her final narrative, a backward-looking story reflecting on the whole process.
What did she say?
She confidently described herself as a physician. She talked about feeling more comfortable, more confident, and crucially, she connected these feelings directly to her experiences throughout the program.
So it wasn't just an internal shift, you could see it.
Yes, it was embodied. And she talked about how this identity played out not just in the clinic, but across different parts of her life, different personal and professional landscapes, as the authors put it. It showed identity isn't static, it's lived, embodied, and develops across time and place.
These examples really drive home. The narrative inquiry isn't just data collection. It's about engaging relationally with these ongoing stories, in context, over time.
And letting those experiences genuinely shape understanding. It's powerful stuff.
It sounds incredibly valuable, but, as you said, challenging. The authors flag 4 key hurdles in medical education specifically.
Yes, and they're not trivial. They bump up against some deeply ingrained aspects of medical culture.
Okay, challenge number 1.
The starting point of inquiry. Most medical studies start with a theory, right? Or a hypothesis tested with questionnaires. Narrative inquiry doesn't. It starts with the individual stories of experience.
So the experience is the data source, not something to be measured against a pre-existing idea.
Exactly. And getting researchers and participants to grasp that fundamental shift, that the lived story is the phenomenon that's a hurdle. It requires a different mindset.
Which must clash with medical training, which leads to the challenge 2, shifting from clinical case studies.
Right. Doctors are trained intensively in that paradigmatic thinking. A case study is all about objective biomedical facts. The doctor's own feelings, their subjective experience, deliberately excluded.
Keep yourself out of it. Be objective.
Precisely. But narrative inquiry demands the opposite. It sees the physician as an actor and agent within the encounter. Their experience is part of the story being studied.
So they have to unlearn that detachment.
To some extent, yes. The authors noted participants found it way easier initially to write about patients than about themselves relating to patients. It's a cultural habit that's hard to break.
Okay, challenge 3. Creating congruent methods and safe spaces. Designing methods that fit narrative inquiry is one thing.
But creating spaces where medical learners feel safe enough to be vulnerable, that's tough. They're under constant scrutiny, assessment checklists, the expert gaze.
Yeah, high-stakes environments, not exactly conducive to sharing uncertainties or fears.
Not naturally, no. So these learning spaces have to be intentionally designed for safety, to build trust so people can actually tell and inquire into their genuine stories without fear of judgment. The parallel charting groups aim to do exactly that.
Makes sense. And the final challenge, number 4.
Multi-perspectival inquiry. Healthcare is a team sport now, right? Physicians, nurses, therapists, social workers.
Everyone's identity is shaped in relation to others on the team.
Exactly.
Yeah.
So truly understanding a physician's identity means understanding it within that web of relationships. Narrative inquiry needs ways to bring in the stories of other healthcare providers too.
And the broader context. Institutional narratives, professional cultures.
All of it. It's complex, getting all those perspectives, but essential for a full picture of how identities are really formed in these settings. These aren't just roadblocks. They're pointers for how medical education itself might evolve.
So where does this leave us? Looking ahead, the authors stress we still need to clarify the core assumptions of narrative inquiry and dig deeper into the ethics, the relational ethics involved.
Absolutely. It's still a developing field. The work isn't finished.
But the potential seems huge, not just for research.
Oh, definitely. You can see narrative inquiry weaving into professional practice itself. Things like ongoing narrative reflective practice for doctors, or even using it directly as a teaching method in med schools.
Helping doctors connect with the human side throughout their careers, not just during training.
That's the hope.
And for you, listening, whether you're medicine or a completely different field, just understanding these two ways of knowing the analytical, paradigmatic way and this narrative, storied way that alone can enrich how you approach things.
How you take in information, how you learn, how you understand yourself and others. It gives you more tools in your toolkit.
It's like realizing knowledge isn't just one thing. It comes in different shapes, different flavors, each valuable in its own way.
Each offering unique insights into, well, the complexity of being human.
So wrapping up, the big idea here is moving beyond just analyzing stories about experience to actually thinking with stories.
Letting those lived experiences, in all their messy contextual glory, genuinely shape our understanding in ways that are deeper, more connected.
Or human.
Exactly.
Oh.
Engaging with the time, the place, the feelings, letting the narrative work on us, it changes how we see things.
So the final thought for you to take away. Think about your own life, your work, maybe a challenge you're facing right now. What are the stories you're living inside of? What narratives are you telling yourself?
And what might happen if you really tried, to think with those stories? What new insights might emerge about who you are, what you're learning?
And where you might be heading next? It's a powerful question to sit with.